So someone wanted to know about when should we be suspicious of mitochondrial disease, and what is the ophthalmologist's role in mitochondrial disease? Of course, mitochondria is super important for energy production, ATP in your body, and so the highly energy dependent structures are going to be the ones that get the mitochondrial disease manifestations. So that's your heart, your hearing, your vision, your kidney, your blood, anemia, pancytopenia, and your brain. So we can get seizure. You can also hear in your gut, pancreas, liver, any organ system, because you kind of need your mitochondria. So if it's just in your eye, the things that we're looking for are chronic progressive external ophthalmoplegia. That's characterized by a chronic, it's for months to years, progressive, it keeps getting worse, and it's an external ophthalmoplegia, meaning the pupil is spared. It's usually bilateral and symmetric, and it comes on in a young adult or a kid. You're going to be looking in the retina for a retinitis pigmentosa-like pattern, and that is called Kearns-Sayre in young people. The RP can be associated with neuropathy and ataxia, and that is called NARP, neuropathy, ataxia, retinitis pigmentosa. We're going to be looking for optic atrophy in all of these patients because the optic nerve is one of those highly metabolic structures. And our contribution as an IMD is to make sure it's not ophthalmoplegia, ptosis, RP, and optic atrophy, but you should be thinking about mitochondrial disease in any patient who has had multi-system failure without any explanation, especially if the onset is in childhood. And so there are particular mitochondrial disorders that come to neuro-ophthalmology, myoclonic epilepsy, ragged red fibers, and those ragged red fibers are in the muscle biopsy. They're the enlarged mitochondria that we're looking at. There's MRF, and you got MELAS, which is mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. So they have these recurrent stroke-like episodes. We're going to test for the lactate, which, as you know, is the entry into the Krebs cycle. So if the mitochondria can't do their ATP thing, it gets shunted across pyruvate, dehydrogenase pyruvate to lactate. Because you're in the anaerobic side of the pathway on the ATP production. And I already told you about NARP, which is neuropathy, ataxia, retinopathy, and retinitis pigmentosa-like thing. We've got mitochondrial neuropathy, gastrointestinal disease, meningoencephalopathy. There's overlap between these things. And if we got the optic atrophy, the mitochondrial disorder is called Leber hereditary optic neuropathy. So Leber hereditary optic neuropathy is our prototype for mitochondrial optic neuropathy. Kearns-Sayre and NARP are our prototypes for RP, Kearns-Sayre and CPO for ophthalmoplegia. Please be thinking about the mitochondrial disorders when we have multi-system involvement, especially if we've got brain and eye and other organ systems with negative imaging. And your job is to consider the diagnosis and get the laboratory studies. The muscle biopsy might show the ragged red fibers, which is the enlarged organelles, the mitochondria, but we have laboratory genetic testing for the specific mutations that are associated with the mitochondrial DNA. As you know, the mitochondrial DNA is circular, and so each of the positions is associated with a different phenotype, even though the genotypes can look very similar. For Leber's, the ones we're worried about, 11.778, which is the most common, 3460, and 14.484. These are the most common mutations in the mitochondrial DNA that produce the phenotype Leber hereditary optic neuropathy. Other conditions, you really shouldn't be fooling around with that. That needs neurology and genetics and multi-system, multidisciplinary. Your job is just to recognize, triage, and refer.